Thank you very much. As president of the Mass Medical Society, I've had the privilege to work on multiple commissions, task force, committees. Most of them are focused on healthcare costs, a little bit of quality, Medicare challenges, and a lot on state and federal legislation. And as you know, Massachusetts was the first state to cover 97.5% of the population with health insurance. I am refreshed by the liberty that you've given me to actually speak about something that I'm very passionate about. Case number 1, February 1st, 2010, Mr. B, 70-year-old black male, lifelong insulin-dependent diabetic, presented to his internist, a new doctor because his other doctor was unavailable. He told his doctor he had left toe pain, and it was so painful, especially when anything rubbed against it. The physician told Mr. B, "That sounds like gout." Mr. B was very upset when he prescribed a medication for gout and never took his sock off. The doctor then offered him a chance to get off insulin. He'd been on insulin for 30 years. "Oh, get off the needle? That sounds great. I'll try this new diabetic pill." February 25th, 2010, Mr. B returns to the same doctor, complaining of increased left toe pain and not feeling well at all. Dr. F prescribes a new pill for gout, and the doctor again did not take his sock off. He recommended him for physical therapy, and the physical therapist was working in his office. So he walked to see the physical therapist, and she requested that he remove his shoe. Because he had some residual weakness from a prior stroke, he mentioned he was unable to bend over and take his sock off. She untied his shoe, wiggled his sock down a little bit, and applied an ultrasonic device used for a diabetic foot, but again, never took his sock off. March 3rd, toe pain so bad, he says, "I'll go see a foot doctor, a podiatrist." And then he was admitted to New York Hospital. Summary of his hospital course: he had an angiogram that actually was complicated by a dissected popliteal artery. What he started with was a ischemic toe, developed calf pain subsequent to the procedure. His hospital course was further complicated by a transmetatarsal amp and a below-the-knee amputation, severe decubitus, C. difficile colitis. This was a video which we had some difficulty activating, but I wanted you to see that Mr. B is a patient who moves and desires perfect health just like we do. Case number 2. Mr. T is a 55-year-old hypertensive black male who presents to a hospital in Fontana, California on the evening of October 26. 1 hour after the sudden onset of a paralyzed left arm, he presents to the ER. His sister, who is an ICU nurse, after speaking with the ER physician, communicates with another physician sibling in another state that their brother has had a stroke. However, a moonlighting nephrologist covering the hospital service says the CT scan was negative. He didn't have a stroke. The family requested a neurology consult, but it had to be approved by an administrator. On October 27th, at 0700, the physician sibling actually flies from the East Coast, Rhode Island, to San Diego, rents a rental car, drives from San Diego to Fontana, California, which is close to a 2-hour drive, arrives in the hospital room, only to see the neurologist arrive an hour later. The family history of Mr. T: mother died from cardiac arrest secondary to a massive pulmonary embolism. Father died of multiple pulmonary embolism. His hospital course was complicated by right-sided stroke with left hemiparesis, atrial fibrillation, massive pulmonary embolism, selective TPA, and an IVC filter. Case number 3. Mrs. LP, 42-year-old black female, painful lump in her breast. January of 1994, gets worked up at the breast center. June of 1994, she develops a cough. Well, her mammogram actually was negative. So The doctor she saw said, "We're going to follow you. Let's just watch it." In June of 1994, Mrs. LP returns and she has a severe cough. She has what they say, well, you have an infiltrate, and it's kind of a funny looking x-ray, and geez, let's send off a sputum and we'll do a gram stain and we'll, send off for cultures. Well, they admitted her for a 24-hour observation, and then she was discharged, later to be called back at home and say, "There's some suspicious cells on your smear." Later revealed she had metastatic breast cancer to the lungs. Linda's mother died of cancer. No one knows what type of cancer. Her hospital course complicated by pneumonia, lumpectomy, chemotherapy, multiple admissions, metastatic liver disease, portal hypertension, bleeding in 1994, September, months later, death. Well, there's a lot of things to say about these cases. What do they share in common? Each one of these cases could have had a different outcome. Can we change outcome? Can we change the trajectory for our patients? Not every patient admitted for toe ischemia winds up with a BKA, a below-the-knee amputation. From the Dartmouth Atlas, a black male is 5.3 times more likely to have an amputation in Mississippi than in Massachusetts. That means some people are a little bit more aggressive at limb salvage surgery and intervention. Something else is at play here. It's not just about healthcare access. If you have healthcare insurance and you don't have the connect the dots, it is almost as though you have a $40,000 check and there is no bank open to cash it. It's about patient empowerment and resourcefulness. While the nation has focused on healthcare access, IT, cost curve, etc., for the purpose of this discussion, we will focus on the intrinsic factors that are associated with successful healthcare, successful health, resourcefulness and empowerment, and healthcare literacy. Definition, this is mine. The capacity to acquire knowledge, healthcare literacy definition, the capacity to acquire knowledge regarding health and disease, taking advantage of resources, resulting in realized gains, let's talk business now, and the improvement of healthcare outcome. And if you consider health and healthcare literacy, let's talk about resourcefulness. What does it mean to be resourceful? Use of information, data, whatever is available, and it's really, in essence, exposure. It's like a kid who wants to get into college. The more exposure they have, the more successful they are taking their SATs and doing well in their grades and getting the best GPA. Isn't it true? So resourcefulness, and then empowerment. What about empowerment? The ability to be confident to solve problems, to get to the next level. It's one thing to think that you can do something, you can quit smoking, you can lose weight, you can go to the gym, you can deal with all of the issues centered around healthy behavior, but if you do not, you are not empowered. Another way to look at resourcefulness is just exposure. In a Harvard Business Review article entitled Empowered, Jay Bernoff and Statler presented this very interesting graph. And what the graph shows you is that you can actually divide employees into 4 categories based on a plot of how resourceful and how empowered employees felt. Employees empowered in the workplace, resourcefulness demonstrated ability to access information. So employees' resourcefulness reflects an innate, learned, or influenced by factors socioeconomically, environmental, because resourcefulness has multiple components to it, doesn't it? We said exposure. Empowerment of employee means the increased productivity, efficiency, endpoints are titratable. So when we know that our patients are really, if we were to extrapolate this, and I will in a minute, that if we knew that our patients were empowered, that would mean that there would be endpoints that are you can extrapolate and say, there is something that demonstrates that patients are empowered. Our focus has not been on patient empowerment or resourcefulness. Observe that in an occupational setting, that the disenfranchised employee is the one with the least resourcefulness and the least empowerment, whereas the best product, the heroes of the whole employment scene, is the person with the greatest resourcefulness and the greatest empowerment. This is my version of trying to extrapolate what they did to our patients. So we can evaluate a similar graph for patient plotting resourcefulness and empowerment. Now, what do we have in quadrant A? Well, you have the patients with poor outcomes. But our approach to it is not the business plan, is it? A lot of times when we see the patients with the poor outcomes, we have a little inkling in the back of our mind that there's something that they did. Not just that it's a conglomeration of things that are occurring here. But is there a way which we as a society can move someone from quadrant A to quadrant C? And we've talked a lot about medical home. How about a health home? How about before it happens? Last week, I was called by a news reporter to actually comment on the fact that Massachusetts has, and this is really scary, an average of somewhere close to 30% obese and overweight children in elementary school. And this is in a state where we have been on the Commonwealth Fund report card, and we've done very well. This is a good state. And one of the things that we don't take into consideration is those children that are in elementary schools who are obese and their BMI is already kind of blossoming are really what we're going to deal with in the future with the diabetes, hypertension, and metabolic syndromes. So get ready. But wouldn't it be much more prudent to intervene at the level of elementary school? And so the priorities of institutions have got to be redirected, if you will. So we focus on how will we bend the cost curve. The best way to bend the cost curve is, guess what? Move somebody from A to C. I mean, if you talk about the top 3 causes of death and issues across the board, not just minority populations, cardiovascular disease, obesity, hypertension, cancer, we can influence things. Healthcare reform and increasing insurance coverage would not change cases discussed. Those 3 cases are really complex, and I will be happy to discuss them further at table 1 afterwards. For instance, I deserve to know what harm could be caused by me cold turkey stopping my insulin. There's a piece of that says, geez, wouldn't that patient go and look on the internet or go find some information before they just decide to cold turkey stop their insulin? 30 years you've been taking insulin. What says in, the morning you woke up and went to see this doctor and he says, I'm going to give you a pill, and oh my goodness, some miracle has occurred. What are the risks and benefits of this procedure, this angiogram I'm about to have? And more importantly, the person who's doing the angiogram, what qualifications do they have? And I hate to say this, but in hospitals, you have cross departments doing same procedures. It doesn't speak to those individuals being competent in those procedures. And as it turns out, minority patients are less likely to have surgery performed by high-volume surgeons in hospitals. And this was reported in ARC last month, that if Black and Latino patients go to a hospital, it could be, an incredible tertiary center. But when they get under that umbrella of that tertiary center, who do they see? Many times, and this is what the ARC study showed, they see low-volume providers. So that if someone has done 4 carotid endarterectomies a year and someone else has done 50, and you have a tiering of patients going to a certain network or a certain doctor because he's young in his training, and that one can go this way. It's like you have cherry picking, even under, as we say at MGH, even under the ether dome, if you will. So and the ARC study also showed that blacks are less likely to have surgery outcomes, even in the tertiary centers, that are comparable to white patients. So this speaks to a little bit of patient empowerment in the sense that you ask questions of your provider. You want to know if you're going to have a procedure like Mr. B in the first case, how many have you done? Okay? Why can't I have TPA? Mr. T's case. You can't have TPA because no neurologist is available for you in this tertiary center that does cardiac disease, does this cabbage surgery, and does all these other interventions. The question for Mr. T's sister was, does anyone in this institution get TPA? Or is it not just for the person who does not complain? Many years I thought, geez, is it that it's all black and Latino get lousy care and then whites get good care? But I've come to grips with one thing, and that is that it really is differential care. True. The Institute of Medicine has proven that disparities exist even for people who have good access, good insurance, and are of middle and higher incomes with black and Latinos compared to white patients. But even I've seen white patients who come in and they have inequities, and it really has a lot to do with the total package. And one of the things I have changed my mantra, and that is that the care is for those who know and those who don't know. Because you ask questions if you know, and you make decisions based on what you know. So, I think that there's so many, it's a multidimensional, multifactorial issues that have come into play. So if we look at resourcefulness and we look at the sum total being of all the things that are part of resourcefulness, minority patients may be at a disadvantage because of all the other social economic things that are involved. McInnes showed in a study that 2/3 of premature death are due to behavioral or environmental factors. How about changing those? What would we do for the 2.4, 2.5, 3.0 trillions of dollars spent in healthcare if we could impact the factors for premature death? So these are all the things that kind of enter into both sides of that equation. So both limbs of that graph can be impacted by both of these. This is a graph just looking at asthma hospitalizations in Boston for children under 5. And you can look at the racial numbers and you can look at the difference in terms of over the years from 1997 to 2002. And you can see there's very little progress. There's actually some deterioration in Asian populations. More than knowing, what is it all about? You know, healthcare literacy in the form of patient resourcefulness and empowerment need our priorities in terms of our greatest investment, and especially with the vulnerable population. I have a challenge for each one of you. Go back to your own institutions and even consider, what are we doing to really bend the cost curve? Because the bottom line is, we know that the best outcomes come when both sides of the equation, the providers, the patients, work together. And that's the most important piece of this. Thank you.